Okay, Pat, you're good to go.
Good afternoon, and thank you for your patience. The first department up before us is the Department of Public Health.
Thank you very much for this opportunity to be with you today. I'm sorry that I'm hearing echo when I'm speaking, but I don't know what else I can do about that.
There's somebody here that's trying to connect that I see. Maybe that's it says Connecticut. Oh no, that's not it. There's got to be somebody that has a duplicate.
It was Susan Logan from DPH. She's muted herself now.
Okay, great.
Okay. Yes, that does sound better. Thank you very much. So thank you for the opportunity to be with you today. I apologize that I'm on my way to a press conference, so that I had to take this meeting from the car. And so I know that you had a number of questions that you had wanted us to address, and that I have brought subject matter experts with me, and we do have responses to a number of the questions that you had raised as well. So how would you like us to proceed through this?
If you could summarize, I believe the first question that we have before us is in your responses is on your lead initiative.
Mm-hmm. Okay, so I think the major thing that I would say regarding lead is that this is really a multi-pronged approach, where there's an investment that we're looking to do to reduce lead that is actually potentially affecting people. So whether it be through lead service lines, through the EJA or bill law that was passed through the federal government, whether it be through lead abatement policies, or whether it be through lowering the lead levels, which is going to happen over several years, but that would change the thresholds for parental notification, for other levels of notification. And so this is really going to be a historic investment at being able to help lead abatement policies through our, particularly in our cities, as you can see in the proposal that we've put before you, with our top cities, which have being most affected with lead, that would be able to address this concern. I have other subject matter experts that can answer more specific questions in this regard.
Does anyone on the committee have a question for the commissioner?
Yep.
Yes, Representative Walker.
Thank you, ma'am, and thank you, Commissioner, for joining us. I know you're busy. So, do you have a plan on how you're going to be doing this? Do you have an actual design of how you're going to address this, or is this in the making still?
So there are some things that are very clearly planned out and that are very clearly outlined through the EPA as well, particularly, for example, with the EJA funds, which is that, for example, with those funds for the lead service lines, there are specific line items. For example, our drinking water revolving fund, the loan fund that we have. Then there's supplemental funding that can go with that. And then a specific line item for lead abatement, then specifically for schools and childcare centers, specifically for PFAS. So these are specific lines. For example, the drinking water revolving fund, where water systems apply, they go through a process that DPH has well established, and then there's an intended use plan that is pretty well established in the areas where we're not established.
Commissioner? Yes. Yeah, you're going in and out, and there's no connection.
Okay. I'm sorry. Then I'm going to ask Lori to step in for me if I'm going in and out.
Okay. So let me redirect my question. So have you been working on the way you're going to roll this out? The whole plan, period. Have you been
Yes.
working on that? Or are you, okay, can you send us your plan the way you're going to be rolling this out? Because I think part of my question is it, I want to know about the things that are going to happen immediately, the things that are going to be worked out a little further down, and then the things that are going to be done the next year. I think we need to see that type of plan with the detail on all of that, because of the size of the amount of ARPA dollars that we're putting in here. It's trying to determine when we are going to be actually starting this process and the dates and everything that are going to be involved with that. So we would like to see detail on how you're going to do this, where you're going to do it, and what the, I guess, 2 years, is it a 2-year funding? Yes. So the 2-year funding that you're planning to do that. So if that would be what I would really like to see with that. So that's okay. Laura doesn't have to, I don't want to, I want the concrete stuff. So thank you. And I'll look forward to seeing that. Okay, thank you.
Good.
Thank you, Madam Chair.
Thank you. Senator Aston.
Thank you very much. Lori, I thought the commissioner was leading into this, but my understanding is that the federal government has a long-standing program on lead abatement. Does this combine with that long-standing program? Is this in addition to those dollars? Will it be a mix of how this is being paid for?
Are you speaking about water, drinking water?
No, I'm the lead abatement program relative to, my understanding is there's a lead abatement, specific lead abatement program funded by the federal government, generally for lead paint and other things relative to that.
There is a program within the Department of Public Health. We have people that work on case management for children that are already harmed. There is a group that also oversees the data. This ARPA funding will go to provide a focus to those high SVI areas and provide a very detailed focus on the lead paint and do the remediation where it needs to happen. When the ARPA money is tied, as the commissioner mentioned, the ARPA money is tied very closely with the change in the numbers for blood lead levels under a 50-45. And so the timing of those two coming together, the funding will provide a very detailed focus on those 11 towns to help remediate those particular locations that are harming children in high SVI locations.
So again, does this include, are there additional funds that the federal government has made available also for lead abatement?
So those funds could
above and beyond
yeah.
the dollars.
The funds flow through other departments.
Okay.
And other agencies. We have 2 grants that fund staff within our program at DPH, but there's HUD funding that is funneled through the Department of Housing and other agencies.
And how much money is in those other programs relative to lead abatement, relative to paint?
We'd have to get back to you on those details.
Okay, that would be great. And then my question relative to the water is, I was talking to a couple of the water authorities, and I think most recently you put out a requirement that they check each unit relative to lead issues. Is there a new ruling out there? When I was talking to one of my local towns that has a very small town that has a water authority, they said they were told to dig up all the water pipes to check them for lead. I'm a little confused. What is the ruling that you guys sent out so that I can correct
Well, right. So there is information that was announced by EPA in December. The one piece of the federal lead and copper rule came out, and this is known as gathering the inventory for lead service line information. They have to get that started now and then meet a federal deadline of October of 2024 to have an inventory of lead service line locations. The second part of the rule will roll forward over the next couple of years, but that's that in December, that's what we've announced to our water systems. That's their responsibility.
So
I'm sorry, if I could just, Senator, if I could just add one other thing to that. We're not asking anybody to dig up anything to, identify a lead service line. What we are asking people to do is to look through their records. Some people literally have to go back and find cards from the 1800s, 1900s that show what was put in and, how old it is. But we're not asking anybody to dig up anything to identify that.
Correct.
thank you, Commissioner. So I think that there's some misunderstanding out there. And I will talk to that local water authority. But my understanding is that water companies have been required to check for lead for a long time now. Is that not true?
Correct. So there's, as a commissioner noted, the rule changed in December federally. You have to start the inventory. So start to look and build the inventory, to the commissioner's point. Now there's another, this is actually looking for the lead pipes, those tap cards the commissioner mentioned, from the 1880s. Go find that, pull it together, get an inventory. It has to be done by October 2024. Your other point, there has been a lead and copper rule since 1991 in the federal law. We administer under our program, under the commissioner, we have oversight of our public water systems. There's systems that have to test for lead and copper under that rule. They test the water quality. That is reported and to our department, and we oversee compliance and enforcement of that rule at the federal level.
Thank you. I just think that there's some misunderstanding relative to what they're supposed to do. So I just want to raise that back to you.
Sure.
I'm sure you know who I'm talking about.
Yes, I do. Thank you.
All right. So my other question is relative to the tobacco prevention. You have $1 million in the budget that's relative to tobacco prevention. And my assumption is that money is coming out of the tobacco prevention fund. Would that be true? I'm talking to nobody. Can you hear me? Commissioner, you're muted.
Sorry, yes, I'm trying to manage the computer and the phone as things are moving, so I apologize. I would like to ask our fiscal team to clarify exactly which fund. I believe that is accurate, but I do want to ask them to confirm exactly where that would be coming from. Is Chuma on the line?
Yes, I'm here, Commissioner. So good afternoon, everyone. To clarify, that $1 million is actually funds that was appropriated in the current biennium under our local and health districts accounts. And what this proposal is doing is merely doing an adjustment to move it from that account to a specific account, a standalone on its own.
So your intention is to take $1 million from the local health districts and move it into a tobacco prevention fund. So I just sort of, I don't understand doing that, because the local districts, we've pretty much finally got them some additional dollars for that. So this doesn't make a lot of sense to me. And we do have a bill in relative to dedicating $12 million out of the tobacco prevention fund to handle this issue. So if you could get me.
So to clarify again, the $1 million was improperly placed in the local and health department district account when it was appropriated. So this is merely a reallocation to adjust that into its own specific account where it should be. It wasn't taken from the per capita grant account.
Right.
So when was it improperly put into the local health district's account?
So the $1 million that was appropriated in the current biennium is what I'm referring to. It was improperly placed in the account that's used to administer the local and health districts per capita grant for tobacco.
In the previous biennium to this one, it was not there?
It was actually in this biennium for FY23, it was placed in that account incorrectly. And what this proposal is doing is trying to move that out from that account and place in where it should be specifically.
Thank you for that, but I just am still trying to figure out, was this the first year that it was improperly placed in that account? But
Yes.
OFA is saying yes. Okay.
Yeah.
Yes.
And just to clarify, this is general fund money. This is not related to the tobacco settlement fund. This is general fund dollars that were added in the last biennium for the first time for FY23 only.
Oh, it wasn't in 22. It was just 20.
No,
23.
correct. Mhm. Right.
Thank you for that. That makes a lot clearer for me to understand.
Thank you.
For that. Thank you, Madam Chair.
Thank you. I have going back to the lead issue. I was looking at the towns that are listed, and as you're developing your plan, it looks like the only town that's in Eastern Connecticut is in Norwich. That is that it's pretty much weighted towards the big cities. And when we originally adopted the standards for lead, which was a long time ago, some of the most passionate testimony came from people who were renovating some of the really charming housing stock in small towns in Eastern Connecticut, and discovered to their astonishment that their children were contaminated by the paint in those buildings. So you're basing that on reporting, and I don't know whether it's because the health districts were smaller at that time or whether there wasn't outreach, but it wouldn't be, sometimes looking at as a percentage of the population is another way to look at it. And I don't want to take it away from those big cities because there's a huge issue there, no question. But maybe if there was a separate thing there for outreach to small towns as well, because they may be underreported, and even if the numbers are small, they may be big in terms of that area. I don't know that. I'm just remembering the families that came up and urged us to do something for people who had acquired property out there.
So I would just comment that, again, what we're looking at is multiple different streams of projects and funding. So, looking at lead abatement, whether it be in paint, whether it be in lead service lines, and there are going to be different areas that are affected differently based on the different contamination methods. And so I absolutely agree with you. We're going to have to keep a broad focus. And we certainly know that our cities have large populations and have that focus because of that. But we certainly will be keeping in mind other more rural parts of the state that also have had these issues.
Sorry, I'm muted. The next question, I'm going in order.
I think Representative McCarty has a question.
I'm sorry, Representative McCarthy, I didn't see you.
That's fine. Thank you, Representative Dillon, and thank you, Commissioner, for your comments along the same lines as Representative Dillon. I did notice because we do have some very historic and older homes in our region, so I'll be interested to continuously monitor what we're doing with the lead abatement. But would your plan that Representative Walker asked about, will you be able to identify and help us understand how the relocation will take place with those families, that if you determine that they need to have their places of dwelling with the lead abatement, how the plan will address and how you will get out in front, because I don't want to see that become an issue for those families, and we want to be proactive to help them understand and work with I believe you'll be working with the housing department on that, if I'm not mistaken. Could you just clarify that for me?
So, again, I think I can comment specifically, the plans that we would have would be on the rollout of how, first of all, in that table that you can see the timeline of a staggered rollout over several years in terms of changing the levels and the areas where we would be focused on. Now, what you're addressing is a bigger issue, not just one of identifying the levels and sort of the work that would need to be done. And so I think this is a bigger topic that needs to be addressed in terms of how that rollout will happen. And I don't know, Lori, if you have other comments specifically on that in our partnerships with other agencies to date, at least that we have as we talk about these things.
Yes, Commissioner, thank you. Yes, so we've thought a lot about the families and the children, and this is what the focus is. And relocation, Representative McCarty, is really important to make sure that it actually is taking place while this plan rolls forward. As the Commissioner noted, we have the year 23, 24, and 25, and the numbers are going down. We're going to work closely with local health as a Department of Public Health to make sure that the families are well supported, that need to be supported as this rolls forward. So part of our statutory authority is to stand up a group to work closely together between the state agencies and the local agencies. So with a focus on the family and the family, the relocation is a big part of that to make sure the children is no longer additionally harmed while the remediation is going on. So to your point, that is one of the major, because we know how interruptive it is to life as it is, but also the child initially to be harmed needs to get well taken care of. And so that's where our focus is, and what the Commissioner's focus is to get together with the local health and to make sure as these numbers get lower, that we're doing this consistently across local health departments and that we are helping local health as much as we can with the funding.
Okay, thank you very much. Thank you, Representative Dillon.
And thank you. Senator Austin, do you have another question?
I do it, but I noticed that you got interrupted halfway through your questions. Did you have another question, ma'am? I can ask mine if you
No, were you talking to me, Senator Austin?
no, Representative Dillon.
Sorry.
No, that's fine. I was going to move on to the workforce issue if we were finished with this. So that but you're actually going in a different way. So I was sort of going by order. So if you have another question, Senator, do it.
Okay, I have another question relative to the use of ARPA funding for our student loan repayment program. How many people are you interested in supporting with this dollar amount? Does anybody know?
Senator Austin, are you asking about FTEs or about loans distributed?
It says provide ARPA funding of $3 million in FY23 and $7 million in FY24 and $7 million in FY25 to support a student loan repayment program for primary care clinicians and to extend the program to behavioral health professionals. How much money does each person get? How are we doing this? What is the plan?
Yeah, so I'm going to turn it back over to Miriam, but I believe a little further down in that document, it says about $25,000 a year for 2 years. Miriam, could you expand on that a little bit?
Yeah, so we're modeling our program after the HRSA funding program, so that the money we get from HRSA through their grant opportunities can feed into a similar program. So they do $25,000 per person for 2 years, and then we would want to offer extension opportunities should people stay employed in Connecticut. So we'll also need to plan to use some of this funding for administrative purposes and to run the program. So I think we need to complete a budget, but the plan is to identify, what will be available for the loans themselves. But again, the commissioner is correct that it's going to be $25,000 per person per year.
So $25,000 per person is equivalent to what percentage of their loan, of someone's loan? Do we know?
It depends on the loan that they have, because it depends where they go to school. Did they go to state schools? Did they go to private schools? So I think that's the type of information that we would collect in the application process.
And do you have any idea of what you could give to us, what is there must be an average loan that people get? No? Yes, no?
We don't have that information right now, but we can look
Yeah.
and see what information is available.
Alrighty, thank you. Thank you, Madam Chair.
Thank you. Representative Walker and then Representative McCarty.
Yes.
Thank you.
Oh.
Thank you. So I'm going to continue on you said Ursa, the way Ursa is doing does their loans? Is that what I heard?
HRSA, HRSA.
HRSA, I could not, okay. Okay. Now, who does anybody in the state do management of HRSA loans now?
I don't know if there's one. I think multiple agencies can qualify for various HRSA grant opportunities. At DPH, we do it by subject matter. So the primary care office, who is going to be running the student loan program, is managing this HRSA application. You're doing it right now in other areas? You're providing this grant for other areas, is that correct? So HRSA gives grants for multiple different subject areas. For student repayment specifically, we are working on that opportunity.
Okay, no, I'm not, but I'm just saying, are you familiar? Do you have the training? Do you have the staffing to do that, or is this something that's going to have to be built up?
So we have the staffing right now to complete the existing HRSA application for additional funding, but we will need staff to run the student loan repayment program.
Okay, all right, but there are other agencies that do this, correct?
The student loan repayment program, no.
No. Okay, so Office of Higher Education doesn't do this.
I think Commissioner wanted to jump in.
Sure.
Yeah, I just wanted to say one thing on this, which is that this is a HRSA application that we are submitting to get additional funds to be able to supplement this program going forward. So the goal is to get this started with these ARPA funds, and then to be able to try to sustain it going forward is to get these HRSA funds so that it can continue to go forward. So Miriam, correct me if there's anything I've said there incorrectly, but I think just for clarity, really what we're trying to do is start this program with this infusion of funds, particularly for primary care and behavioral health, and then be able to apply for these HRSA funds that will help then fund and staff a program that can be sustained going forward.
Okay, is it a matching, or is it's not matching? It's just whatever you apply for, that's what you can get. Okay.
Correct.
Okay, all right. Okay. So okay.
And to answer your question, I don't believe there's other student loan repayment programs in the state, at least for primary and behavioral health care, which is what we're proposing right now.
Okay. Okay. All right. Thank you. Thank you for your answers. Thank you.
Thank you. There are more hands up, and if you don't mind, Representative McCarty, I'd like to go to Representative Gilchrist and Candelaria because they haven't asked a question yet. Yes, Representative Gilchrist.
Great, thank you so much. I'm going to be focusing on the community gun violence piece, and thank you so much for the answer to this question. My first piece is, what do you mean by mini grant? What would a mini grant be? Do you have an idea of the amount at this point?
So Susan Logan, are you on the call? Would you be able to field that question?
Yes, I can field that question. So in mini grant, basically what we want to do is award folks who complete an application or request for funding, community-based organizations. So it's going to be a competitive process. So we would like to award up to 8 community-based organizations that provide evidence-based practices for about $80,000 a year over a 3-year period.
So would they get $80,000 each year for 3 years?
Yes.
Okay, thank you. Okay, wonderful. And then right now, Project Longevity is its own, I believe, line item. I might get that
Yes.
wrong, but it's considering, which I think is great, that you'd be using this department to also evaluate these programs. Would
Yes.
Project Longevity, is the idea that they then would apply for these mini grants, or would they still be a standalone?
They would still be a standalone as part of the money that's already allocated to them through the state, through the OPM. But they would be, able to, or, they would have the opportunity to apply for the mini grant as well for additional funding.
And would there be a way to ensure that their evaluations are included when looking at the full picture by DPH?
Yes, we could include them. Even if they aren't a mini grant. We'd like to be able to evaluate all of the programs that are doing evidence-based work, one of which is the Project Longevity.
Okay, wonderful. And just one more question, is that okay, Rep. Dillon? Okay. And will there be dedicated staff for this program department?
So right now we have a program, an Office of Injury Violence Prevention. So we are going to get the project started. We don't have staff in a community violence program currently right now. We're hoping to establish that at some point in the future with funding, if we can get some. As far as the work that we want to do for this project, this ARPA funds, we wanted to get a contractor to manage the whole process. So we're thinking get a contractor to administer the funds, the ARPA funds, with oversight from DPH. We have close working relationships with injury prevention centers and other organizations that could do this kind of work. They'll be managing the mini grants over the next 3 years. We're also, through DPH, would be hiring the evaluator and also helping to work and support the Connecticut hospital-based violence intervention program collaborative run through right now the Hartford Communities That Care with Andrew Woods as the executive director there.
Great, thank you so much. I appreciate the information.
You're welcome.
Representative Candelaria.
Thank you, Madam Chair. I just have questions on 2 programs. On the student loan repayment program, is this for new graduates or existing graduates?
Anyone who has student loans and working in health provider shortage areas would be eligible to apply.
Will be eligible. I know they asked the questions about what will be the amount of that loan program, but I know we don't have an answer there. My other question is, for those, let's say for those clinicians that work with FQACs, for example, I know that they offer this a repayment program through the federal government. Are we going to monitor if the students are receiving student repayment loans from different entities? How is that going to be managed?
We'll need to consider that. I know that there is a group working on the exact work plan and criteria for giving out loans. So I think that that's something that we'll continue to have in our discussion, but a decision hasn't been made there. And I will kind of touch on, we will have, the loans will be $25,000. It's just
Okay.
the number of loans we will give out has not been determined yet.
No, so if
And I
we
think
give
just
out,
to, I'm sorry, just to second that, which is that, I do think that as we're giving out these loans, we want to be aware of what other loan repayment people might be getting. And so working out some of those details will be part of this process as we establish this program.
all right, thank you. And I guess the repayment program, do they have to commit? I don't know how you're envisioning the program. Do they have to commit to work for a nonprofit institution for an X amount of years? How will that be rolled out?
So it's my understanding that in the past they've worked as long as you're receiving the loan repayment, you must work in a health provided shortage area. Whether it's not necessarily classified as a nonprofit or not, because it could be a hospital system. It just depends on the location of the workplace. But as long as they're receiving the loan repayments, then they will have to work for those locations. If they want to apply for an extension of the 2-year commitment, then they can do that, but they would have to remain working.
Got it. Thank you for that. And on the community violence prevention programs, we're allocating 1.9, almost $2 million, which I think is not enough, right? When we're seeing a lot of the, especially in urban communities, we're seeing a large increase in gun violence. Now, what is it that we're looking for? We're looking at best practices, but what exactly are we looking for to ensure that these dollars are utilized in? So is it more about working with the youth and getting them trained, or are we going to provide some type of stipends? I'm trying to understand what is it that we're looking for to accomplish with these almost $2 million.
Do you want me
Susan,
to
can
take
you-
that? Okay.
Yeah, go ahead, Susan, if you can take that, please.
Right. So we're looking to, well, it depends on the application and actually who applies for the mini grants, but we're hoping to get a mixture of different programs. So youth-based, young adult-based programs, ones that work, say, for instance, Mothers United Against Violence, different street outreach programs, violence interrupter programs. So there's a lot of these programs and really supporting them and supporting their growth and building their capacity to really outreach to all of their community members that are at highest risk.
That's it. Thank you. Thank you for those
Thanks.
answers.
Thank
you, Madam Chair.
Representative. And I wanted to follow up on the community violence, I guess, Commissioner or Susan. When we say evidence-based, what
Mhm.
we're doing now, is that based on the e-coding that's in the Chimes database? Or if I want to know, how much we could attribute to homicide by guns at X hospital, that would come from the mandated e-coding that we did. Is that true? And what other data source would we be using?
Right. So we have several data sources for gun violence and stabbing as well, because that's another issue that we look at. So we have the Chime data, which is our ED data, as well as our hospitalization data. We have real-time surveillance data, which we use for situational awareness, which we can, there is a gun traumatic injury, gun-based traumatic injury definition in there now. We have epidemiologists on staff who do monitor these data. We also have a federal funding through the CDC related to Connecticut. It's called the Connecticut, Violent Death Reporting System. So we work really closely with our Office of the Chief Medical Examiner, our state police, and local police departments throughout the state to gather information on homicides that have occurred throughout the state, and not just like the demographics, but the circumstances around the homicides, whether or not they're drug-based or group violence-based, things like that. We can get some more information. And that's part of our CDC work we've been doing since 2015.
That's very helpful. Thank you. Because one of the problems with the original reliance on the Chime data was, if you go to the emergency department, you're in the database, but if you die on the street, you're not. And so obviously that it's difficult to capture. So that's good. And
Yeah,
that,
we get that data monthly. We get that death data monthly from the medical examiner's office.
okay, that's great.
Mm-hmm.
And you get fed money now because of the sexual assault. Is that true?
Yes, we do. We get some state money for the rape crisis centers, but we also get federal money. I believe it's $2 million, about $1.6 to $2 million a year for rape crisis, rape prevention and education. So we work closely with our rape crisis centers as well as our sexual assault, the Alliance Against Sexual Violence Prevention.
That's right.
Yeah.
Okay. Is there any potential, I don't know this, to get any federal dollars on the gun violence prevention?
We haven't been able to get any gun violence prevention funding, only the surveillance funding. So that's something that we would love to get. We just recently got suicide prevention funding. We've been monitoring suicides, and of course, some of those, many of those suicides are done by guns, firearms. But yeah, we just recently got that last year. We're hoping to get some sort of funding, but we don't see that on the horizon yet for gun violence prevention.
Well, this whole initiative in the 90s kind of turned the NRA into data nerds. So it's wonderful that we were able to get our data collection in place before everything went nuts.
Yes,
I appreciate that. Thank you very much. And
welcome.
I believe Representative Baker and then Representative McCarty.
Thank you, Madam Chair. This is, I'm not sure, this is directed at the commissioner or somebody who can answer this question in regards to some follow-up to Project Longevity's line. I'm just kind of curious as to, is the ultimate goal is to kind of bring Project Longevity? Because I know there's some other monies that an OPM line item that fund money to Project Longevity, and your line item is that's for that position. I believe that's going to sort of like do administrative type of thing. Is that
Right? Yes, so we have a position, it's a contractor. So it's,
Okay.
we're suggesting it's the Injury Prevention Center at Connecticut Children's and Hartford Hospital. But that hasn't been written in stone yet, but they're the ones that are going to be given the funding just to really do the work of our agency. So we don't have the staffing currently right now. And since it's such a short 3-year time period, we don't, at this point we can, but it would take a long time to hire people in order to administer the program. So we figured we could get the contract out and, get that in place. They'll do the RFP with, DPH very involved and other stakeholders very involved with that. And then we get the folks on board, hopefully, as soon as possible. So the 8 different community-based organizations doing this work. And if Project Longevity wants to apply for that, that's up to them. But we would score each application based on, the certain requirements, which we haven't laid out just yet, but they'd have to be, best practices or evidence-based practices. They had to show a need that they would need to build up their capacity in order to do the work that they do. We would be evaluating the programs, go over the next 3 years to see their effectiveness. So yes, that's all be part of that contractor's work. And work and do some health education as well with law enforcement, other first responders around emotional support and crisis support of victims and their families.
So once this report is kind of done, who's this information going to be shared with? Who's going to facilitate in terms of sharing it with? I mean, is there something that's going to be a report that's going to be available to us? And,
yes.
The committee, and how is that going to be facilitated to Project Longevity or as just in the community on the
Right. Well, we hope to be able to continue our partnerships and strengthen our partnerships with different organizations throughout the state working in community gun violence prevention and other types of violence prevention. We have a really strong network right now of folks across the state in different injury prevention centers. We're just really getting on board with folks like the hospital-based violence intervention programs. Most of our work as an Office of Injury and Violence Prevention has been with not so much with community gun violence, but more around sexual violence, opioid overdose prevention, now suicide prevention. So this would be a new area for us, but we do have the capacity and the partners in order to establish those connections and strengthen those connections. So anything that we do right now in the work that we're doing right now is very transparent. We have a lot of state partners that we disseminate information with, that we communicate with. We have a lot of data on our web pages for the main programs that we're doing. So that's, we'll have that information available to anybody that wants it.
Yeah. Thank you for your answer.
Mm-hmm.
Thank you.
And are these second questions from Representative McCarty? Did you get to ask your second question yet?
Yeah.
Right.
Thank
Thank
you, Thank you very much, Representative Dillon. I just very quickly wondered, and when we looked at your responses in relationship to the nursing home, and there's tremendous shortages right now with the nurses in the nursing home. So I'm just curious as to how the department may reach out with the student loan repayment program to the nursing home facilities in particular, if there'll be any extra initiative to reach them. And then if we could have some information more about the CNA training. I know we offered those trainings and has increased the CNA pool, but if we have more information on how many availed themselves to the training, I would appreciate that. Thank you.
Thank you. So a couple of things I would just comment on. So first of all, we want to make sure that people getting the student loan repayment are working in areas of high need. And so, I think there are going to be some homes that certainly are in those areas. Some may not be. So, I think that there are, but there's a multi-pronged approach regarding the healthcare workforce shortage that we're looking at. The student loan repayment is just one of many things that are happening at the level of the state. Whether it's working with the Office of Higher Education, whether it's working with the Office of Workforce Strategy that is really developing those pipeline programs for nurses and for different hospital systems and be able to get people jobs. So I think that there are multiple different avenues to address this issue of workforce shortage. So for the nursing homes in particular, as you're mentioning, the student loan repayment may be one, but not all homes may qualify in terms of where those people are working in terms of the areas of need. So that's just one comment I wanted to make. On the other piece, I don't know, Lita or somebody else from Healthcare Quality and Safety on the issue of the CNAs that was asked. Is there somebody else on the line who might be able to answer?
Yeah, thank you, Commissioner. I can speak to that. Since the last executive order authorizing the temporary nurse aid program went into effect early in the fall, we've had 383 people complete the temporary nurse aid training. We've also accelerated, made it easier for nursing homes to apply to us to approve their certified nurse assistant training programs so they can do on-the-job training for these TNAs. So we have been watching that very carefully and promoting that with the nursing homes. So we see that TNA program as a pipeline into the CNA program, and it seems to be working. We also have partnered with Advancing States, which used to be the National Association of States Units on Aging, on a job bank called Connect to Care Jobs. And we've been asking the temporary nurse aides, CNAs, nurses who are interested in working in long-term care to submit their resumes through that system. And we've put on board all of the nursing homes, assisted living, other long-term care facilities. And now we're reaching out to hospitals. So that's a little job bank sort of way to connect people to long-term care jobs, specifically in healthcare jobs generally. And we're hoping to re-up that program for the state going forward.
Okay, thank you. Thank you for that good information. And thank you, Representative Dillon.
Thank you. And Commissioner, we're hopping around and I just realized I'm trying to tack on 10 minutes to our original schedule, but I think we're at risk for being disrespectful to developmental services. But your Commissioner, your testimony was spot on. There have been many years where the Department of Public Health was a stepchild, and everyone's excited about the work you're doing now. So I hope it continues. I didn't want to end without asking about the wastewater, because people in New York and in Vermont are very excited about expanding. Well, I think Vermont is rolling something out, and New York is expanding. And I wondered what the status of our own wastewater monitoring is, especially, I guess I was thinking of opioid, but it could be others.
Yeah, so, I wanted to just clarify that regarding, SARS-CoV-2 and COVID versus opioids. And so I'll just give you a little bit of a heads up in terms of COVID and SARS-CoV-2 first, which is to say that, the CDC has really stood up a pretty expansive wastewater system. You can go online and see it at any point in time. And we already have data that's coming in from Waterbury and Bridgeport, which are cities that have already enrolled and are already submitting wastewater specimens. In addition to that, we have many other cities that are either in the process or already getting on board and in the process of submitting their samples. And we are putting forward a strong effort to get as many cities in the state of Connecticut on board, submitting their water samples to the CDC so that we can monitor COVID rates going forward, so that we can anticipate further surges. Now, regarding your question on opioids, which is I think what your original question was actually about, it started out, looking for COVID, and they found sort of serendipitously that opioids could also be detected, and that this maybe could be an interesting another avenue of investigation to be able to monitor opioid use as well. And so I think that we don't have a lot more in that regard. I will ask Susan if she has something else that she would like to say on that. But I think that's sort of where we stand, as like a promising other alternative for opioids. But I would say that we are using it and will use it to monitor for other infectious pathogens also, not just for COVID.
And I wanted to, it seemed to me, and last year is a blur in some ways, but one of the many presentations I went to was Jordan Pasha, who was talking about what they were doing with the wastewater. And it sounded like they had the capacity to identify the variants. If that, now the CDC that I saw a week ago, 2 weeks ago, had picked a number of towns around the country, maybe 11, and it wasn't clear to me whether how sophisticated their analysis is. Like if I'm monitoring the city of, Woodbridge, is it going to be a binary yes, no COVID, or is it going to say, what the level is, or is it going to say, what the variants are? I don't know if that's a current question, but I am concerned about like whether we're making the best use of the science we developed during the pandemic.
Yes, and this will continue to evolve and change. What the CDC is offering in the testing that they're doing right now is first they look at a percentage change that happens from one sample to the next and across the various different cities. And so 11 cities, that may have been a while ago. Now, if you look at that map that they offered, there are hundreds of cities around the United States. And I can say that in the state of Connecticut, we've got, somewhere between 6 and 8 that are, coming on board. And we're trying to get even more on board to try to blanket the state as much as possible. So there are two things that they're monitoring. One is for change. The other is for presence, and what percentage of samples that are submitted have a presence of SARS-CoV-2 or not. And you're right that Jordan was also looking at variants. I think this is sort of the next step to this. And I think that this is a good point in time where the CDC is starting this in a more broad scale, because then hopefully going into the fall, looking at variants, looking at the various different testing will become even more robust going forward.
You're muted.
I'll probably follow up on that, but not right now.
I have one more. If I could just ask Representative Dillon for some information. That's
Sure.
all. No answer required right now. Can you, for all of the ARPA dollars and carry forward dollars, can you give us a list of all the contractors that you're outside of the state contractors that you're planning on hiring to deal with a variety of different programs, and what other state agencies you're planning on dealing with the ARPA dollars relative to things like the student loan repayment, higher ed conversation, and relative to the gun violence, all the programs that you started listing off when that was going on. So that's my list of questions right now. No answer required right now, but if we could get those answers, that'd be great. Thank you, Madam Chair.
That's great. Thank you very much, Senator. Any other questions for the Department of Public Health? Well, very exciting presentation and thank you for being here.
Thank you so much. I just want to say I really appreciate all the enthusiasm and support for public health, and we're glad not to be a stepchild anymore and appreciate all your support. Thank you very much.
Thank you.
Okay, bye-bye.
Bye.
Manner, I guess I would want
Representative Dillon, the team from DDS is in.
Great. Next up, the Department of Developmental Services.
Good afternoon, Representative Dillon and co-chairs Senator Abrams and ranking members Senator Summers and Representative Kennedy. I'm Jordan Sheff from the Department of Developmental Services, and I'm here to follow up on questions asked to us at the Appropriations Committee, and I bring along a number of my colleagues from DDS to assist me with answering those questions. I'm wondering if you want some of the questions have a fair amount of detail because of the short.
And I don't know. I'm looking for. We did receive it before this meeting, although not quite enough in time to speed read it. Why don't you just identify some very quick points, maybe in 5 or 10 minutes? I'm sure interest in the subcommittee.
Depending on how long this goes, I'm planning on being.
Thank you, Representative
If
Dillon.
this goes long, I have to.
Rod, there we go. So I'll go ahead and do that now. And I just wanted to say thank you again for the opportunity. So I'm going to, and with a short turnaround time, we would have liked to have had it to you sooner, even if we had. Some of the questions required so much detail that you still probably wouldn't have had time to read and digest it all. But I'm sure you'll have plenty of time after I'm done today to peruse those materials. The first question was around money put into the private provider community with regards to the wage increase. We provide a detailed table. I want, for those of you who are looking at the detail in that, the columns across indicate the provider, and then the 3 accounts. We've used the account numbers, which you may be familiar with, some of you more so than others, but those 3 accounts are behavioral, from left to right, our behavioral support program, our day and employment options program, and our residential program. So as you read those across with the totals on the right, and on the 4th page, 5th page, totals of all those expenses at the bottom. With what has been processed thus far, $31 million of that money has been put into the provider community to date. And you can look down that list for if you have specific concerns around providers in your district that you've heard concerns from. You can look down that and find them on the left-hand side of that column. The second question was around more funding for infrastructure improvements. And the question was, is there bonding for this and how is funding provided? I'm going to read briefly the answer from Deputy Commissioner Gilbert at DSS, as I mentioned last week, that the money for physical plant improvements for residences is held is through the room and board process, the room and board rates at DSS. He provided some information for you and asked me to get back to him if you had additional follow-up. Up until the current biennium, rates have been frozen, and I think that's where a lot of concerns have come from over many years. He indicates in his answer with the most recent biennial budget for FY22 and FY23, inflationary increases have been provided, and starting with rates beginning July 2021 forward, rates now allow for a fair rent pass-through for all capital improvements. Therefore, any state-approved home improvements will be included in the facilities room and board rates on a prospective basis. It should be noted, however, that such reimbursement is provided over the useful life of the improvement and therefore provides a stream of reimbursement over time as opposed to full payment of the improvement immediately upon completion. That was his response to that question. He was wondering what level of detail you might like, and we're happy to follow up with him if there's additional questions on that. We provide a lot of information about Southbury in pages 5 through 9, including some of the training requirements. We were asked around training for individuals there as it relates to workers' compensation. In the table, you'll find a list of buildings because there were questions about buildings and how many are there, how we use them, and we've indicated that their status is either open, partially open, seasonal, and then Department of Agriculture through statutory, I think it was through statute, was conveyed a portion of property out there. They have 5 or 6 buildings that are under their care. We then list a small handful of buildings closed, and then those that are mothballed. There are many of those. And then there's 4 properties at the end of that list at the middle of page 9 that have been demolished. And we try to describe the type of facility, the type of building it is. You might be, just to give you an idea of the type of building that is still there where they exist. The specific question around workers' compensation at Southbury, we were not able in the short turnaround time to ascertain a site-specific amount of workers' comp specific to Southbury. The agency spent $13.4 million in fiscal year 21 on workers' compensation, and Department of Administrative Services reports that $7 million in DDS workers' compensation expenditures have been made as of December 31st, 2021. These expenditures apply to the entire department, as I said, and we are not available at the facility level of detail. The trainings are listed across. There are 2 trainings in particular that relate to workers' compensation. Physical management training, which is how we help individuals, support individuals who may have behavioral concerns in an effort to keep both the individual and the staff safe. As well as body mechanics for any lifting, transferring, working with people who may need assistance with mobility or with healthcare, bed-related care. I believe Representative Abercrombie asked about the emergency placement money. I included in my answer some detail that when this money was first put in the budget several years ago, at the end of the Malloy administration, we worked to stand up several emergency service responses. My concern was that we would place a certain number of people and then be out of emergency money. And what we really needed to do was to try and help stave off emergency placements. And we have a fair amount of supports that we run out of that program now. We have a step-up, step-down unit operated by Public, where $2.4 million of that is spent. We have a step-up, step-down private provider partnership opportunity where they assist with those types of opportunities as well for $1.6 million. We have private providers who help us in terms of mobile or crisis response for $1.2 million. And internally, we have beefed up our in-home family support team so that we can assist with mobile crisis directly, as we're most familiar with the families and most skilled to do so. And there's $400,000 of that money included. And that's how we come to the $5.6 million. I have additional statistics not included in the responses in terms of the number of people we've supported with that money that we've been able to return to community-based placements and to return to their homes, in some cases their family homes. Other times a long-term 24/7 placement. And I think that it's been a really important turning point for us in terms of supporting providers and families who may reach a point where they can no longer feel safe supporting their loved one. And we are able to help them stabilize and return to the prior setting in most instances. We've talked a lot this last week about ARPA in several hearings. You have a ton of information in front of you. I've answered some questions at a separate hearing yesterday regarding ARPA. And rather than go through the whole ARPA presentation again, I'd be happy if at the end of my few minutes of going over these details, if there's specific questions about ARPA, in addition to what we answered yesterday, I'd be happy to answer those. But you have a detailed amount of information in front of you that includes one of the questions I couldn't answer specifically but potentially any ongoing costs after the ARPA spending window is over. That was a concern from a number of folks. I think Rep. Case may have asked that question, but it may have been somebody else. And so that is detailed in there as well. And that gets us all the way to page 17 of the information provided to you. With regards to the DDS budget for camps and community engagement, a specific question from our session last week. The camps aren't funded through service fees for much in the way of overhead and infrastructure. This is an opportunity, particularly since they had a big downturn in revenues at the private camps over the last 2 summers. Some didn't open at all, so there was no revenue generated, and they still had building and maintenance costs. But we'll be working with both our private providers as well as the 2 public camps for how we will distribute that $5 million should the legislature choose to approve the governor's recommended adjustments in this budget. Dental care, there was a question about rates. That information is included in answer 7. My coordinator for dental services is unfortunately out on a personal leave briefly. And so I could not get the question answered specifically about chair visits that she normally provides. And as soon as she's back, we'll make that information available, but she coordinates that across all our dental clinics. But we did, through our MOU with UConn, expend nearly $400,000 in contracted dental services at some of those clinics in fiscal year 2021. There were then questions about day service utilization. That chart is provided for you by payment month through the course of the pandemic, and a summary around pre-pandemic averages and post-pandemic averages. The concern being a return to full operations, and that is on pages 17 and 18. It also includes the stability payments. So without the stability payments that we've made, also referenced in the ARPA, those providers would have lost revenue, lost employees, and individuals would have lost opportunities to return. As I mentioned in my prior testimony, it's a combination now of emerging from the pandemic and the workforce crisis that keeps our numbers diminished in the manner that they are in terms of utilization. Although I do believe we are trending up as we can bring on more staff, and we believe that the ARPA funding will allow us to do that, as help with that as well. Number 9 was around DDS retirements. And you'll see in that chart on the bottom of 18, April's the big month for us with 95 anticipated retirements. And we are working to address those concerns, and some of the details as to how we do that is included. And then the specifics on the IT consolidation. We've given you a list of all the IT employees, how they'll be consolidated, and what some of the current non-division related duties were. So regarding the BITS division, not our department. So that's broken out for you. And then there was a question around the in-home supports rate. And at the time the question was raised, there was some confusion around whether it was a specific provider or not. We chose not to answer regarding a specific provider in public testimony or public response, but happy to have that conversation offline if legislators so choose. In general, there are some concerns from our provider community around the in-home support rates. And we are working with a small group currently discussing those concerns and looking at how we can resolve that problem and work towards a resolution. I hope Representative Dillon, I got that done for you in about 10 minutes, and I know that was fast.
Thank you very much, Reed. I just want to flag something for follow-up on the workers' comp. First, do I understand you that that's a $7 million expenditure right now?
That's what's included in my notes, Representative Dillon. So I believe it says $7 million through fiscal year 2021, according to what DAS has. If any of my staff want to correct me on that, I welcome it.
I asked about that. It's not a new concern for me, but that when workers' comp was handled by your department, we were able to get a specific data on the location of an injury and what kind of injury it was. And that was the whole Big Six thing. And now if it's been moved over to Department of Administrative Services, are we getting less information now if it's over there that we can't get site specific?
Representative Dillon, I don't know if it's specific to the move of it or the quick turnaround time and what they would need to pull out from the larger set of data. Scott, do you have any detail on that? Scott McWilliams, CFO for DDS.
Yeah, Jordan, it relates to the time when we used to get, in response to, Representative Dillon's request, we got a more detailed reporting from the Department of Administrative Services. So I think in time we'll be able to get a similar level of detail.
That sounds great. I mean, it would be really, I assume a lot of the expenditures those injuries have a long tail, and so a lot of them are not new, but it's helpful to identify with the trend lines how we can protect people. And I think part of my question to you the other day, that long night of Thursday, was who is in charge of, does DAS just pay claims, or who is in charge of looking at the data and developing a plan to reduce injuries anywhere? But historically, Southbury was the problem.
Southbury, while it remains with a census of about 136 people, has a pretty good experience for us over the last few years, is no longer our largest body. The rest of public is a big, the balance has tipped there in terms of where our resources are. But there are internal safety conversations that go on all the time, in addition to the support we get through DAS for more global issues. So some of the injuries are unique to the type of work that we do. Technology has helped in terms of how we transfer, lift, and move people, as well as enhanced training around the physical management techniques that we use.
Great. Well, we'll continue. Thank you very much. Representative Abercrombie and Senator Austin, and then Representative Sims.
Thank you, Madam Chair. Good afternoon, Commissioner, and to your staff. Thank you so much for being here. Just to follow up on page 9 with the emergency placements. So you talked about a 6-bed unit. Did you add any beds to that unit, which started about 2 years ago?
When it first came online, it was only 5 beds. We took a facility located at our Hartford Regional Center in Newington that had previously been closed. We made modifications to that because of some of the safety concerns for some of the individuals who've been in there. While it is a 6-bed facility, it's not a static number. There's a clinical team that oversees that, and depending on who's there and the nature of their concerns, it's not always at a census of 6. Depending on the balance of the milieu. And I believe off the top of my head, our goals with people coming in is a maximum 90-day stay, extendable to 6 months. Despite my little bit of angst about meeting those timelines, we have consistently, that clinical team and those direct care staff out at Hartford Regional Center have consistently produced good results, and people have not stayed there long term.
And so I guess my follow-up question is, why have you not applied with OPM to get any of the mental health dollars, right, to be able to expand this unit? Because we know that even though we're going to be adding 12 beds to CCMC, it's still not going to be enough. And I really believe that this unit, and I want to give you and your agency kudos, because I think this was a really incredible opportunity for our young people to have some place to go to get stabilized, because ERs should not be the place that they do long-term, right? It should be like triage. But why are we not expanding on that when we know that we have such a dire need here in the state?
So thank you, Representative Abercrombie. We are really proud, and I'm very proud of the work we've done there. I'm going to call on my Chief of Staff, Katie Rock Burns, to see if you will talk about some of the things that we're doing with regards to enhancing those opportunities. That the program I talked about in Newington is specifically for adults. What we have done though is we're bringing some additional services online for children. And Katie, can you talk about a few of those services?
Yeah, absolutely. Thanks, Commissioner. Right. So the step down unit, that's the 6-bed on the Hartford Regional Center campus, is serving adults. But within existing appropriations, we are developing several programs out of our BSP account. For children. So we are working on actually using the model that's been so successful for adults, developing a step down unit for children. It won't be on an existing campus where we typically serve adults. It'll be elsewhere, but we are looking at partnering with our provider community to develop a similar model for step down unit, as well as opening a couple of overnight respite opportunities for children who are served in our BSP program. I think, largely the family community and the provider community have said that some of these crises might be avoided if we could offer more planned respite and planned, sort of breathing room. So we've heeded that advice, and we're looking at developing a couple of out-of-home respite programs for children in the BSP program as well.
And I just want to add to what Katie furnished for you there, Representative Abercrombie, that we, for a couple of years, and in part due to the pandemic, we lapsed some money in our BSP program, but our intent was to try and get these things off the ground. The pandemic interrupted one of our staff, Tammy, has been, it's taken a while to get that the RFP on the step down unit for children able to work, because it was really tough to bring online during the pandemic. But we're in the midst of that now, and the respite centers will also be an opportunity for some of those children that you have seen or heard about at whether it's at Midstate or CCMC, who are struggling in the ER waiting area and not having an opportunity for placement. So we see the combination of those multiple factors. So we did have conversation with OPM. It just didn't require additional resources. We were able to do it with the existing BSP structure. And we sit at the table with our sister agencies, DMIS and DCF, DCF being primary on children's issues and DMIS on adult issues. And are part of all the conversations with their design. Is specifically both Commissioner Navarrete and Commissioner Durantes, as opposed to having things exclusively for people with IDD, the more that that we can be included in their other developments and get services directly through, instead of building something twice, once for us and once for them, that we're working with them to be included in the things that they're developing.
So I think that's great. I see there's $4 million in the behavioral services line item, which I think kind of adds to what you're saying. I just want to, for the record, say that I believe in this step up, step down unit. I believe it's the way we should be going as a state. And I can't tell you in strong enough words that we need to do this faster. We need to make sure that our adults and our kids, not just the kids with the IDD, but other kids, especially kids that are on the spectrum, we know that they are in a holding place right now in their ERs, and we need to figure out how we incorporate them into some of these services. And I know you don't have to comment. I know you agree with this. I know you've been on the front lines of it, but I'm just getting impatient, because these families have been waiting a long time, and this is such an opportunity, and we have these dollars. We should be doing it now and not worrying about the 23s and the 24 and 25 into the future. We should be taking these dollars now and spending them wisely. And in my opinion, this is a wise investment. So thank you, Commissioner. Thank you, Madam Chair.
Thank you. Senator Austin.
Thank you very much, Madam Chair. So Commissioner, when we talked about the increase of the funding, we talked about this when the other day. I'm very concerned about the compression component of the funding relative to the staff that have been there, say 15, 20 years and are now leaving because they're making what somebody who's been there 6 months is making. Do you have plans to address the compression issue? And to be fair, I'm not just bringing this to you, I'm bringing this to DSS, DPH, every group that's out there, because I find that we're not dealing with the compression.
Thank you for the question, Senator Austin. The methodology that Secretary Barnes brought to bear at the end of the Malloy administration to create a minimum wage within DDS makes us a little different than my colleagues, but consistent with Secretary McCaw, consistent with what Secretary Barnes had provided with advocacy from a number of places, allowed not only for the floor to be raised from what was no minimum wage to $14.50, now to $16.50, about to go to $17.25, but they also allowed for a 5% increase for all staff making above that minimum wage. And that was applied to all positions. Certainly I don't recall with Secretary Barnes if there was a cap. I can remember specifically with Secretary McCall, we did no cap. So when we did the analysis, we looked at all positions with the organization, and everybody was either moved to the minimum wage. If they were already making that or above, they got a 5% raise.
And I don't mean to interrupt, but that was during the Malloy administration?
The 5%, the cap was, if there was a cap, it was during the Malloy administration. Secretary McCaw and her staff discussed with me, and we agreed to not have a cap where the 5% was applied in what she approved and worked through with 1199 and then with the rest of our providers last spring.
So relative to that, I talked with many of the larger providers, Oak Hill, Camp Horizons, all of them. They have indicated over and over and over again that the people above the minimum wage component got a 3% increase. That's it. So I think that the 5% is not, you know, I need to see those numbers. And even in the numbers that we got from Claudio, relative to that, there is no 5% anywhere in the numbers that he gave us out of OPM. So I really think we need to go back and look at those numbers to make sure that we're all making an apples to apples comparison on this issue, because we do have a lot of people leaving this community. And in part, it's because the people who have been there long term are not getting a pay increase. And so I think that that's a problem. And so if we could, I'd like to delve into those numbers a bit more. So if you could even reach out to Oak Hill and Camp Horizons and talk about this, that's something that I think is a problem. My second question is, and I just quickly glanced and maybe it's in there and I just didn't see it. The funding that is to improve the camps, do we have an outline of which camps? Is that in your document? You're muted, sir.
Thank you, Senator. That is not in the document. And one of the reasons is I identified a newer camp in the northwest part of the state that I was unaware of. And so I didn't want to leave anybody out. And it's not yet approved. So we haven't done outreach through our provider networks and through our families to identify all the camps that might be eligible. So it certainly would include Horizons, Creaser, Harkness, Camp Q, and I'm missing one off the top of my head. But there's one now affiliated with Lark, I believe, up in Torrington. That's only a couple years old. I'm not sure where they're at, but so we don't have a process yet because it's not yet approved, although we're thinking about how we would dole out those dollars. But in my mind, it would be any of the camps where we fund camperships that we could assist with capital improvement projects.
So when you come back again, if hopefully somebody has approved something along that way so that we can actually see that, because I believe it was Kathy Abercrombie who said, Representative Abercrombie, who said, hey, listen, we want to see, and I'm not certain if it was on this Zoom or another Zoom, we want to see the dollars out there. We don't want it happening 9 months, 10 months later, which is what happened with the ARPA funding most recently. We need to see the dollars out there now, not in a 7 to 10 months. So that's why we're asking these questions. So if you could get us that information, that would be extremely helpful.
Well, we will work to get you a list of all camps. I don't know that I can spend money ahead of July 1st if it's not.
No, but we can get it through, this time frame. We're just finishing Actually, we're nowhere near finishing the ARPA dollars, and it's March. So, and that budget was signed in June. So, you know, March makes it a little bit hard for us to swallow. So, thank you. Thank
Yes,
you very
Senator,
much,
thank
Madam
you.
Chair.
Thank you, Senator. Representative Gilchrist.
Thank you, Representative Dillon. Thank you, Commissioner. And I apologize if this was asked. I was a little in and out, but speaking to the benefit pool funding awards, what I'm hearing from providers is that this is one of their most pressing issues. And they're also telling me that they've submitted the documentation from the provider network, but there's a large discrepancy between the total submitted by the providers and the funding that was originally allocated. So just wondering what the process is to determine the funding for each provider and the anticipated timeline for the distribution.
Thank you, Representative Gilchrist, for the question. So to be clear, the way the budget was set up in this fiscal year, only 5 million of the 30 million was going to be made available. The annualized figure in the next year of the biennium would be 30 million. Secretary McCall is recommending an additional 15 million, which will bring the annualized amount in that benefit pool to $45 million. Going through the process as was negotiated, the asks from that pool of money were in excess of $70 million. It may have been even in excess of 80 million. I remember them being in excess of 70 million. So we had to go back to take a look at what was submitted and requested and analyze that. My understanding is that we're working with both 1199 as well as OPM, and I have a meeting with OPM set up later this week to talk about how that will be administered. And we are awaiting guidance on how we will distribute those funds. Because they will eventually roll into rates, I can tell you that it's a much heavier lift to dole that money out, 5 million now, bury it, put it into the rates, 30 million, and then 45 million, and keep having to tweak that. So knowing that it would be the full 45 million and only having to go through that sort of rank order with what will be covered benefits and what will not under that proposal, and coming to some agreement will allow us to do it once instead of do it 3 times. Scott, I don't know if you have any additional comment on that, or did I cover that okay?
I think you covered it pretty well.
All right. Did that answer your question, Representative Gilchrist?
Yes, thank you so much. I do have one additional question on the camps as well. Just wondering, it's my understanding that this is general fund money and not bonding. Why is that the case?
Scott, I don't know the answer to that.
So the way this is working is this HCBS ARPA money, which is the funding we're using for the camps. We're going to spend the money out of appropriated funds and then receive federal reimbursement on it at the tail end.
Okay. Okay. All right. Thank you. Thank you, Rep. Dillon. Thank you, Commissioner. Thank you, Scott.
Thank you.
Okay, thank you, Representative. I still have questions about the waiver and how we're, because the numbers weren't clear, and we might want to follow up on that after now, because I know Demas is waiting. And about all this, we're transitioning people out of Southbury, but we're putting money on the table to transition people out of group homes as well. Is that true? And we have concerns about whether some of the rates are adequate to support some of the in-home that we're going to be so-called incentivizing. Is that true? Is that an accurate summary?
That's a pretty accurate summary, Representative Dillon. We are in discussion with providers about the in-home support rates. There is additional money to sort of incentivize that movement. And just as a reminder for those on the call, the system was built through the 80s and into the 90s, largely relying on group homes as what people with intellectual disabilities needed. And a lot of the people who we support were placed there because that was the menu item we offered and featured. The opportunities for people on the wait list, some of those people need the group home level of care. We think that with some of the advancements in technology, as well as some of the good work our providers have done in habilitative care, that some people could live more independently than in a group home. And that's why we're looking to leverage within existing resources, opportunities to shrink the wait list and to promote independence. And that's all that there's linkage in all of these recommendations, but I understand that it's not clear how they're all connected. And I'd be happy to engage further on that discussion.
That sounds great. Thank you very much. And I know you did get it to us late, but we did ask for a lot of detail. So I appreciate you being so responsive. It looks like we are concluded with developmental services. And so thank you for your time.
Thank you, everyone. We appreciate it.
And we are now joined by Demas.
Good afternoon.
Good afternoon, Commissioner.
Where would you like me to start?
Yes, I'm going to try to pull up your responses.
We can certainly do that if you like.
Well, go ahead. That's all right.
Jump in?
Yep.
Okay. If at any time you'd like us to share our screen, be happy to do that. I have with me Mary Kate Mason, who is our legislative liaison, Cheryl Aurora, who is our chief financial officer, and Colleen Harrington, who's the deputy commissioner. The first questions, Rep. Dillon, were on the SUD waiver and funding changes. So there's some money that comes in and some money goes out. We did receive money to fund 25 positions. Specifically, those positions would be at Office of the Commissioner to oversee the program, as well as direct service staff and utilization nurses on site at CVH. There is money in other expenses for funding the ASOs, Beacon Health Options, and Advanced Behavioral Health. The biggest chunk of money that comes out is $24 million. That comes out because we are no longer paying the claims. The claims will be paid by the Medicaid Authority or Department of Social Services. We will continue to pay grants. Those grants were increased so that we can provide dollars to pay for services for folks that are not eligible for Medicaid but still need services. And so that's $11.6 in. The total is a net negative 5.7. That's question one.
Okay.
Moving on, will clients receive the same services under the waiver? The short answer is yes, and those services will be enhanced. So any money that is brought in through the federal match will then be infused into the different levels of care that exist now, and those will be become more robust. Clients will be assessed. You have the different dimensions. I won't go through them, but there are 6 dimensions that clients will be assessed by the ASO and also by the provider to make sure that it is a medically necessary service. That's question 2. Question 3, also regarding the SUD waiver. How will the waiver impact providers? All of these providers currently provide services to Medicaid members. They will continue to do so. It's about 900 beds. Those, as I said earlier, the services will become more robust because the federal match will now be invested in the continuum of care. And providers have up to 2 years, so 24 months, to get up to speed with the additional benchmarks that for the increased rate, there are some increased expectations related to staffing patterns and integration of care. So that concludes the waiver. Any questions on that? Okay, moving along to ARPA funding. Which ARPA initiatives have ongoing costs and what's the impact of one-time funding? So you have a grid on page 5 that lists the different ARPA initiatives. The department and the state are committed to continuing in the out years most of the projects For example, the diversity training, that is time limited. I think anything that has to do with training can be memorialized in either our learning management system, train the trainer models, recordings, like we're doing meetings on Teams and Zoom. Those can be recorded for the out years. Telehealth is also time limited. We're hearing that some folks may not have access. We don't know how many, but may not have access to the proper equipment. And so we would be able to supply that to folks during the pandemic to make sure that they can receive services by telehealth. The other services are funded in the out years. And we will also be exploring any Medicaid match or braided funding that would be available through federal grants, opioid settlement, or like I said, Medicaid billing. So that's ARPA. We did share with you in the packet the RFP for the electronic health record. It's only 5 pages. It's a list of questions to try and cull out what the vendor can bring to the table. We really can't share anything beyond that because we're right in the middle of contract negotiations. And so per the contract standards, that's all that we can share with you at this time. So you can certainly look at that document when you have a minute. Forensics beds. So this is also a project that is funded through ARPA. How many beds? Where will they be? Who will provide services? We just started a pilot project in Bridgeport. So that's for 3 beds. We're working with one of our providers there, Regional Network of Programs. So they are familiar with the clients that we serve, and they do a good job in the community. So that is the model. We don't have any data yet because the program has just started, and that was started with some small dollars through OPM. We'd like to expand on that program to New Haven courthouses and New Britain courthouses. So the total cost of that would be 1.9 million or 127,000 per bed. So we're looking forward to that. And basically, it allows us to provide services that ordinarily would be provided in an institutional setting to provide them in the community, which is much more consumer friendly, less traumatizing, and gets people back out into the community more quickly. So we would be going from 3 beds to 15 beds, 5 beds in each one of those towns. Mobile crisis, current utilization. So we received or had contact with over 13,000 individuals over the course of last year. We have an in-depth report that we had to do for the legislature, and we attached it. So you have that in-depth report. It is primarily, I think folks were interested in who provides the service for us, and it is a statewide service. Each mobile crisis team, of which there are 18, has its own catchment area. It's primarily our local mental health authorities, but there are a few additions. It's Danbury Hospital. There's a consortium of providers in New Haven that offer the service in conjunction with Bridges, BH Care, and CMHC. So they work together, and it's been working well for years. So we have not broken that apart. But you have in the detailed report, it lists all the funding, all the hours, and where we expect the programs to be with the additional 2.5 million that they should receive. So that's mobile crisis. Peer supports. How many peers will this place? Which emergency departments? And so the language is that we would place the peers, so 1 peer in each of 12 busy hospitals. So we would look at the data to see and operationalize that project. This is new money, so we would really need to go through the data and look at which hospitals that would be and how that would be operationalized. But that is an exciting project that has been extremely successful on the substance use side. Housing vouchers, which services does this funding support and where are the units located? So this funds existing vouchers where individuals will then be able to receive the services that we deliver or our providers deliver, which wrap around folks in their homes so that they can be successful in living in the community. It's an evidence-based program providing case management, budget management, care coordination, working with the landlords, working with the neighbors, really doing some skill building with folks. Again, long-standing program that's been extremely successful in keeping people in the community. How many clients are in need of telehealth equipment? We're not sure of that yet, but what we have done with other programs is run the dollars through our ASO. DMIS will come up with the parameters, who is eligible, what the caps are in terms of, is it $100 a person? Is it $500 a person? So we would come up with all those parameters. And then one model would be to use an ASO to help us get that money out into the world. Through our providers, by the way, who would make applications on behalf of their clients, or clients would apply through the providers that they interact with. How does DMIS, and this is the diversity, handful of diversity questions, how does DMIS currently address training, service selection, provider contract, and service delivery through diversity, equity, and inclusion lens? So we do have a department within DMIS that has been in existence for decades, Office of Multicultural and Health Equity. And what we have been doing is partnering with a full service inclusion consulting firm that has been able to offer diversity trainings. It's mandatory, 7 hours per employee. I have taken it myself. This was pre-COVID when we were able to do things in person. It's a very engaging training, and we continue to offer that to our employees. Some of the topics are leadership, mediation, supervision, relationship building, courageous conversations. We also collaborated with DCF and the governor's office to host a series of community conversations with Black and Brown women, Black and Brown men, looking at mental health during COVID, looking at support systems during COVID. That was very successful. So those are some of the projects that we have done. Our social justice committee meets with union leadership on a regular basis for us to get any feedback from staff. And our contractors are asked to, in their contracts, it's required that they provide their staff with 3-hour diversity training. So many of our programs are offered in the community, like Amani Breakthrough in New Haven, and our mobile mat vans, which are statewide. We go to the client or the potential client, and that way it's very low barrier. So we can adapt our model to whichever community we are serving. So those are some examples there. The next question, Rep. Dillon, was around the services geared toward the Hispanic community. And you have a list on page 13 of all the different contracts that we have: Catholic Charities, CASA, CMHA, Hartford Behavioral Health. I won't read through all of them, but it's a $5 million infusion of dollars across the state, again, to provide those multicultural services. Next question on page 14, can you identify nonprofit organizations operated by the BIPOC community and what services they provide? In this question, we chose to provide an example of how we approach inclusivity. I think it's a very good example. We have a contracted media organization that we've been working with on a handful of campaigns. a serious mental illness campaign, an alcohol use disorder campaign, a coach campaign. And we've really used data to inform these campaigns and placement of programs and materials, what language they're offered in, and which vehicles through which we rely the message. So if you look at page 14, it lists different placement of different digital billboards, for example. And so this particular contractor chose Hartford, New Haven, Waterbury, and Bridgeport based on data of the most diverse communities. They then looked into which newspapers and radio stations would be serving the individuals of these communities, again, as an example, and we were able to implement based on that data. So that's an example of how we modify our services accordingly. The next topic is HR, human resources, and you asked how many vacancies, active recruitments, and anticipated hires. So we know there's a national behavioral health workforce shortage. If you are to literally do a query to our core CT system, which is the state's human resources management system and financial system, we have 810 vacancies. That includes full-time, temporary worker retirees, part-time, emergency workers, temporary workers. The number has a lot of noise in it, unfortunately, because there are duplicates in there. And I'll explain as you look down on page 15, if you have that in front of you. We split out the vacancies by facility, and by far Connecticut Valley Hospital definitely has the most vacancies. Of the 810 vacancies, we already have at this point in time, and these numbers change daily, 65 commitments, meaning we've already sent letters out, but they're not yet removed from this vacancy list. So there are 65 positions that have been accepted. There are 390 positions that what we call are in active recruitment. So that means they've been vetted through DMIS and through OPM and are somewhere in the system. Either they're posted, they're in the interview process, their background checks are being conducted. Somewhere in that process, there are 390 recruitments happening. There are 355 positions that are pending further review. So that's the piece that has some noise in it. When it's reviewed by DMIS or OPM, we may decide this is no longer needed. This was a duplicate. This is an overlap with someone that already started. This was a durational employee and that project is completed, so we don't need to backfill it. So that's the last column. So currently, even though we're bringing on board and are actively recruiting, our active recruitment, in fact, has actually doubled since last fall, since August or so. But it is a true statement that retirements and vacancies are causing attrition, and that is definitely higher than our employees being onboarded. So we are actively working with DAS to improve our hiring rates, especially for those hard to fulfill positions, which brings us to the next question 15. So what we have been, how many additional retirements do we anticipate over the next several months? So we only know when people notice us. And so far, we've been noticed of 136 that would retire between now and July 1st. So that number may increase because folks usually give a 60-day notice. So we're not quite there yet. And so that number may increase. We are in the process within DMIS with our human resource partners that work on site with us, creating a staffing unit which will focus solely on the staffing and the filling of positions and not any other job duties. We're also creating candidate pools So there's a process in filling a position. We have to follow the rules of the contract. One piece of that is going through the list of folks who may be eligible to accept that position should they want it. And so once that list is cleared, then we can go out to the general public and hire. And so as people apply, we'll put all the LPNs together, all the RNs together, and we're trying to make that process more fluid so that once we clear that vacancy list, we could go right into this pool of candidates and bring folks on board. We're advertising in well-respected journals for some of the professional positions like nursing and psychiatry. Outreach by Talent Solutions for all the job postings is also listed. Social media, minority-based organizations, community organizations, colleges, career fairs, etc. And we've included a list of career fairs that DAS would be participating in over the next couple of months. And that's also in your packet on page 16. Then switching gears a little, page 17, you had asked for the number of people historically using the problem gambling services. So we've provided that in a grid up top. It seemed to be hovering around 2,300 folks annually. There was a little bit of a dip actually during COVID. So there were 1,964 individuals in fiscal year 21 that accessed those services. And we will continue to follow that data. And since we do keep track of it, we can see if there are any increases following the changes in Connecticut state law. It's really been, we have a long-term unit, problem gambling unit that since 1984 has been offering prevention, treatment, and recovery support services. So you may have heard of our program, Better Choice Treatment, and that is specific for folks that are struggling with gambling addiction, for their families, their spouses. They can come in individually, they can come in with their families to receive specialized treatment around those issues. Folks also have telehealth options in the problem gambling division, peer recovery supports, people with lived experience. Of course, there is the hotline or helpline through Connecticut Council on Problem Gambling. A lot of gambling awareness. We have regional gambling awareness teams, and then some, I guess I would call ambassador type programs through Asian American Pacific Islander population. So folks from that ethnic background are then trained to be ambassadors around problem gambling and bring that message to their community. We also have a youth project that our regional behavioral health action organizations are involved in, where youth are matched up with a media campaign and are able to create their own media campaign around problem gambling. Again, this ambassador model of having youth, young folks, then talk to other young folks to carry the message. You had asked for detail on funding and associated programs on substance use, cannabis, vaping through our prevention department. That is question 17 on page 18, I believe. And it is over $14 million that we have invested. Most of those dollars are federal dollars. There's over $10 million on the federal side, a couple $1 million on the state side that are invested in different prevention efforts, AUD, local prevention councils at the level of the municipalities, programs for parents through Courage to Speak Foundation, Governor's Prevention Partnership. We do have programs that are specific to youth vaping and tobacco use. That's in the bottom grid, and that's about $2 million. And that includes the staff assigned and all the materials that are involved in those youth vaping and tobacco campaigns and monitoring. We also have 2.5 million for cannabis for staff, a media campaign, and a consultant. And 25% of cannabis tax revenue is earmarked for DMS for prevention and treatment once it starts coming in. So those are our prevention programs, very well resourced. Representative Dillon, you asked about the military support program, which I can report is alive and well. Continues to carry out the mission. Over $300,000 is invested. We have 2 permanent community clinicians that answer the phone, respond to all inquiries related to case management questions that folks may have. We can connect folks to resources. We can connect folks to what we call embedded clinicians. So those clinicians work with over 30 National Guard units and are a resource and support to over 5,000 members. Dealing with issues such as PTSD, depression, anxiety, and substance use disorders. The really interesting thing about this program is it's completely confidential, so folks don't have to go through the Guard to get those services. They are clinicians that are outside of that, and all confidentiality is respected. And there's some stats there for your for you to look at. 51 calls to the call center. We will also pay for services if someone lacks insurance. That's not a usual case. Most folks do have insurance where they can access a therapist, but we will pay for those claims if the person that is uninsured. And lastly, the tobacco funds. So the last time that we know that we received funding was in 2015, and that was $287,000. So that was a little bit of money a long time ago. And those funds were used for the compliance inspections with the city police departments. I really don't have any more information than that. The historical knowledge about that fund is gone. But I would refer you back to the detail on the prevention document on page 18, which really shows that we've continued to invest in tobacco retailer inspections and secret shopper initiatives and prevention efforts. So I spoke really, really fast, got through all 20 pages, and am happy to answer questions.
Does anyone have any questions of the commissioner? That's a lot of material. Thank you very much.
You're welcome.
Representative Abercrombie.
Thank you, Madam Chair. Good afternoon, Commissioner, and to your staff. Thank you for being here. Just a quick question. I'm a little confused on the telehealth. So currently, what are these individuals using for telehealth, and why will they not have those devices in the future?
So some folks, good question. Thank you for that. We've been reaching out to some folks just by, landline and telephone. They may not have a smartphone that can handle video, for example, or they may not have internet access. So we would like to help folks in any way we can to be able to be connected to their clinician should they not be able to receive those services in person.
So we're currently not talking about people that are currently getting services. We're looking at the future for individuals that may be eligible for telehealth, but currently don't have the devices. Is that correct?
That's correct. And somebody right now may be, for example, receiving services by landline, and maybe they can't see their clinician. And this is just, off the top of my head, maybe we could provide a library of tablets for people to borrow, or, some alternatives for folks so that it's not just a telephone call, there's more of a connection there. But that's just one example. And your explanation is also true.
So, and I apologize because there were a lot of pages there, and I'm also on Human Services right now on a public hearing. So I'm trying to pay attention to
problem.
both. But did you say in your in your documentation how many individuals we're talking about? Like, do we have a number?
I do not have a number. This is a new program.
Okay.
What we have done in the past is kind of do the advertising to our providers so they can let their clients know. And that includes both our state operated providers and our private nonprofit providers. And that way it's vetted through their treatment team to see what they need and how we could be helpful to them.
So are you thinking about any of the opioid settlement dollars to be able to be used as a technology grant, similar to what we're doing in DDS? Not we, sorry, I don't work for the agency. What the commissioner and his team is doing in DDS.
Certainly, we would take a look at any proposal like that that can offer low barrier treatment to folks.
Great. Thank you, Commissioner. I appreciate it. Thank you, Madam Chair.
Thank you. Representative Walker.
Thank you, and thank you, Commissioner, for all the details. I will hold my questions until I read all the materials.
Okay.
Because
Okay.
there's a lot of materials here, and I have some questions, but the answers may be buried into further down. So I don't want to ask them and be referred to it. So thank you for providing us with that information, and I'm sure I can get in touch with you guys if I have any questions.
Absolutely.
Thank you.
Commissioner, thank you very much for all of the detail, which I too am trying to read very quickly. But on the military support program, which the previous governor tried to eliminate, actually the people from the military department fought for it. And over time, I actually used to check in very often after Commissioner Kirk didn't, who sadly we lost during the pandemic, but just did an amazing job creating that. And his sense of it when we were trying to see where people's problems could go was that there were reentry issues, that you might have a spouse. I would say, how bad can this get? And what are you seeing? Because it was really kind of a gut thing. And it was an agreement to use the Fairfield Hills dollars. And so it wasn't, and everyone believed, we wouldn't be at war very long, but, that didn't happen. So he said that you might have a spouse, if you have a conventional marriage or whatever, let's say two people, spouses taking care of children with behavioral issues, anxious about a missing parent, that parent comes back at the end of deployment, walks into the family and says, I can't relate to you. I want to be back with my buddies. And a loss of a sense of mission, which very often opened the door to all kinds of behavioral issues. The compromise that protected that program was to not admit any new people. Is that true?
No, we continue to admit folks.
I wonder if you could get back to us on that, because there have been so many triggers for people who might be returning, from theater, and people may have stereotypes about what they think a military town is, but we have a Veterans Administration hospital here, and a lot of people in the National Guard, and many other people in the regular military too. So even aside from people in other parts of the state, they're everywhere. So any further information you could provide would be terrific.
Sure.
New people have come in, and that's great. Thank you. I see hands are up. Representative McCarty, and then Representative Amicardi. Do you have a second question?
Yes. Yes.
Okay, great. Okay, so Representative McCarty first.
Thank you very much, Representative Dillon, and thank you, Commissioner, for your very detailed responses. I'm sure we'll have more questions as we continue to go through them, but I did have a question also with Representative Abercrombie on telehealth, and wondered if you will be looking with coordinating with other agencies to find out, because I know in some other departments we're also looking at that same initiative. So just to have that coordination between the agencies, that's number one. And then two, with your retirements and with your new advertising that will be going out, do you have a time frame for that? Because as we're going through this session, and hopefully we're going to have a lot of different grant programs to attract the professionals that we need in mental and behavioral health, and just curious about whether you had any plans for that attraction to Connecticut, how you will be using the advertisement. That may be, I don't know what your time frame is, but hopefully we can find some tools to attract, because we do have some real shortages. So thank you.
I appreciate that. I can say that these are not time limited, so we will keep deploying these strategies until we have the positions filled. So there is not an end date, because it will be continuous, and we know that additional retirements are coming.
Great, thank you.
Thank you. Representative Abercrombie.
Thank you, Madam Chair, for the second time. Commissioner, just a quick, whoops, sorry, peanut butter in my mouth. Just a quick question on the 988, which is the new hotline for the National Suicide. Has there been any thought about how we will incorporate this? Some of us as policymakers have been thinking about this. And one of the ideas we had was, would it be worth it to do a contract with United Way, who already does, they're really the gatekeeper for many services, where they could also have a unit for the 988. For those of you that have never had a tour of United Way, it's a pretty interesting place. And because it's one building, they have different floors that do different intakes. So some is about Husky, some is about Care for Kids. But have you put any thought into who would be the gatekeeper for the 988 hotline?
Yes, and your point is a good one. There are some efficiencies, obviously, that would happen using an entity like United Way 211. So they are at the table with us. We did receive a small grant to do planning. It was like $130,000. And so DES, DMIS, and DCF, along with United Way, were the key partners in this. So the answer to your question is yes, they are right there with us. And we will be working with them as we transition from the National Suicide Prevention Line, which will be incorporated into the 988.
Great. Thank you very much, Commissioner. I appreciate it. Thank you, Madam Chair.
Are there any other questions from the committee? No, well, I'm sure that there'll be a follow-up, Commissioner. I know even on issues such as diversity and the importance of trust in the provider for good outcomes, that different ethnic groups are not monolithic and they come from different religious traditions or different countries. We hear a lot about that, and I don't know, so that I know that there'll be high interest in the programs and in scrutinizing the testimony and making sure that we get it right there. So thank you very much.
Thank you for that, Representative Dillon.
So the Office of Health Strategy isn't here with us yet, so I think we can take a little break. Oh, wait a minute, spoke too soon.
they're starting to pop in. Hold on.
Thank you so much for your testimony, and thank you so much for all the work you continue to do under just unimaginably difficult circumstances the past 2 years. And really, it applies to so many people who
So we have one person. So I'll let you know when we've got the OHS team in.
Okay, we're going to take a brief break then.
Brief.
A stand up.
Stand up and stretch break. Yeah.
Right. Okay.
Hello? Hello?
Hi, Mr. Baker. Hello, Mr. Baker.
Speaking.
Hello.
Vicki Veltri and her team are here, I believe.
Terrific. It's great to see you.
Hello, good afternoon. How are you?
Just fine. Hope you're well.
I am. Thank you. You too. I hope so too. All of you.
Did you receive the questions that had been posed by some committee members?
I think I'm talking about Covered Connecticut.
Yeah.
I think there were some questions about Covered Connecticut.
Yes, ma'am.
So happy to talk about that. Do you want me to just jump in? I know I'm missing one person. I'm hoping one of my team that's on could get Kim, please, who's our deputy, to come on board. Thanks for getting us on early too, by the way. Yes, I think that there's a couple questions about Covered Connecticut. So the Covered Connecticut program, sorry, I don't know what's going on with my voice these days. We started that last year. I want to thank everybody for supporting that to allow us to provide additional coverage to up to 30 to 35, 40,000 people in the state of Connecticut. We're in the preliminary portion of the program right now, which is covering caretaker relatives of children who are eligible for Husky. So that is a much smaller population than the eventual program, which is going to roll out to childless adults as well. The program is covering people between 160% and 175% of federal poverty, and which is just above the current income limit for Medicaid, which ends at 160% of FPL. So this program is really about the adult coverage. So the program has started. As of today, the enrollment is at this point only about 862 people. We can explain why we're at that number and why we think that number is going to grow rapidly beginning in July when we get the waiver. And I'll explain the waiver too if you want. But we have 862 people right now. What's going on is we're still in the public health emergency. So because we are still in the public health emergency, people are being retained on Husky coverage who are likely above current Medicaid eligibility limits. So under the federal rules during the public health emergency, Medicaid had to keep people on, even if those people were no longer financially eligible for Medicaid. And there has not been a detailed review of the income limits of the current people on Husky. There will be when the PHE, the public health emergency, ends, because what's going to happen is month by month, DSS will have to look at all those people on the program, see if they're in fact now eligible for regular Husky, or whether they may have a year of transitional medical assistance, meaning that they get to stay on Husky if they have earnings for like another year. So there's, we think, a substantial number of people in that group. So in order to kind of ensure that we're doing everything we can to enroll people who might be out there and who are not on Husky A and eligible to enroll, we have significantly upped the outreach that Access Health is doing with community partners. And we have extended the open enrollment for that program until June 30th. So that's actually really good news. So my thing would be, if you know anybody who needs coverage and is between those income brackets, you can still get coverage on Access Health all the way up to June. So that's really what's going on with the period right now, which explains why we've spent, excuse me, I have to get the number up here. My apologies. I'll get it up here, but my email is floating around here. But we've spent so far, I have the number up here. Let's see, 1 second. Not a ton of the appropriation that we were given yet because of that. So at this point, we've only spent about $680,000 of the appropriation this fiscal year for that reason. I don't know if you want to know about the waiver, but I can fill you in on that. So if you want to.
My understanding, and I know that there are a lot of folks on the committee who may have other questions. My sense of what our members were asking about was how many people were enrolled and what were the associated expenditures. You identified what you thought some of the barriers were to the rollout. I think there is some interest in next steps and how quickly, what you would need to get to the next phase, how that would, whether there's a bonding need or or IT need or to get to where you need to go.
So we don't have.
Question.
Okay, thank you for that. We, at this point, so just so you know where we are in the process, and I think there's another public hearing, if I'm not mistaken, tomorrow again, via the MAPOC, if I'm not mistaken. I'm looking up at Representative Abercrombie, who's right up on the top of my screen here. We've been having a public hearing process as part of this program. We agreed that we would look for federal funding to match the state appropriations that are in the budget. So we scurried and ran around, and some of us became honorary actuaries and kind of went through all this numbers crunching and got the 1115 waiver concept paper into the feds to get that federal match. We had to have a couple public hearings, and then there's going to be a hearing in front of, I believe, the 17B8 hearing, which is Human Services, Appropriations, and who am I missing? Somebody else. That's it. Human Services and Appropriations for the waiver application. We're feeling pretty confident that we'll be able to get the waiver close to July on time, which means federal match right away. But we also really feel confident that in July, that enrollment number is going to shoot up, because the people that are the childless adults that are in this 138% of FPL up to 175, there's many more of them than there were caretaker relatives who are eligible for this program. And there's many more of them who are just not covered, and they don't have transitional medical assistance available to them. They don't have kids. So we feel pretty confident the numbers are going to shoot up to where we all want them to be when the waiver goes in. Technologically, OHS is really not in need of any technology supports for the program. We are really doing the billing with the carriers and getting their invoices and paying them back. Where the technology lift is over at Access Health, where they've had to redesign some of their queries on the screen and some of their displays. Anything that they would need budgetarily would go through the Access Health Board of Directors. And they are independently funded, so they don't come through the state budget. So I hope that helps.
Thank you. Now remind me, when is the timeline for the childless adults?
Right now, we're targeting July 1st. Unless we hear something different from CMS, I think we're feeling pretty good about getting that waiver on time or as close to on time as possible.
I guess that's the appropriate term. It seems weird that we should define people, only that way. But
Well, I think we feel pretty confident. We're going to launch it, right? We have funds and we've been funding people out of state this appropriation that the legislature provided us, but we feel like we can cover people. I don't think we're going to let the waiver stop us from getting people covered with this vehicle, but I do think the waiver is going to come pretty soon. If it's not on July 1st, shortly after.
Okay. Does the subcommittee have any questions? The Office of Health Strategy? Representative Abercrombie, yes, I saw your hand reaching towards the.
Sorry. I'm sorry. It's really hard on your phone when you've got your other computer hooked up. So I apologize for that. And I try to use one little try to use a little finger so you don't see my whole hand. But anyways, so thank you, Vicki. Just a couple of things for my colleagues so that they understand where we are in this whole process. And I need to raise an issue that has come up. So on the 115C waiver, because this was new, there was an added step that we normally don't have to do with waivers, and it added another public hearing that we had to have on it. And so with talks with DSS, we thought it was acceptable to do it through the MAPOC meeting, because those are all providers that are going to have to implement this program. So just so my colleagues understand, we didn't cite the legislative process at all. We just added the extra meeting to providers that are really going to do the work. So that's the first hearing. And then once this gets closer, then we will have the appropriate legislative meeting, which will be, as Vicki said, through Human Services and Appropriations. So I just want everyone to understand on this subcommittee where we are with that. The other thing that the elephant in the room is the roadmap and all of the negative comments that have been coming out about that. And I will say, quite frankly, a lot of misinformation. We have tomorrow, we don't have a hearing, Vicki. Tomorrow is the MAPOC executive meeting.
Oh, is that what's on my calendar? I thought it was.
Yeah, no. So this is just the executive meeting tomorrow, which we're going to talk. Bill Halsey will be there from DSS. We're going to talk about what's going on with the roadmap, where we are about the negative, and then we are going to add it to the MAPOC regular meeting of the bigger body so that we can really have this out in the open so that one, all of our colleagues can hear it. And then two, that we can really give factual information, because there really is a lot of misinformation out there. And even the commissioner of DSS has said publicly, we are not doing capitation in Medicaid. There is no talks about doing capitation in Medicaid. So just so my colleagues know, all those emails that you're getting, we are working through that, and we will have an explanation and then an answer to all of those comments that are being put out there. So I just wanted to state that for our colleagues. And thank you, Vicki, because I know you've been on the receiving end, which as policymakers, we know what it's like to be on the receiving end of negatives. So, just thank you for hanging in there, and we're going to get through this.
Well, I thank you very much for that comment. Actually, we had a hearing today on the benchmark bill in which I explained this, that, the primary care roadmap was really something we were exploring heavily on the commercial side. We had talked to Medicaid about it, but the idea was to better resource primary care in the state of Connecticut and to figure out completely voluntary options that providers could get resources. But really, our focus has been on transforming primary care and getting providers the resources they need to transform, meaning build out these care teams with community health workers and nutritionists and pharmacists and track patient data by race and ethnicity and language. And you can't do that like the way we're normally funding primary care. So we had sort of committed to people, if you can set up these practice teams and demonstrate that you can do all these things, like including behavioral health integration and patient-centered care, all these things, that we would help you transform. Like we would provide some resources to help you transform. But then you could do that any way you want. I mean, how you get paid about it, we don't really care, but we were offering potential options. And unfortunately, it's been really misinterpreted. So I appreciate your comments, because no, OHS has no authority over DSS at all, nor would we exert any. And Commissioner Gifford and Brad and Richards, who's the medical director, have been very good to work with, but know that, they're going to pursue their own strategy, and they'll be doing it through, as you said, Representative Abercrombie, doing it through the engagement with the MAPOC.
Right.
It's totally fine with us, right? We're not.
Yeah.
So thank you. I really appreciate your clarity on that.
Thank you, Madam Chair.
I'm supposed to go to tomorrow? I think I am, right? I don't know if I'm supposed to go to that.
If you got an invite from David Kaplan, you are more than welcome.
Okay.
Representative Dillon, before we proceed, we have a number in the waiting room, and I wanted to check with Vicki to see if this is one of her people, 860-559-9778.
I don't recognize that
number.
one.
Okay. All right, then that person's gonna sit in the waiting room. Thank you.
But if you could indulge me for 1 second, I'd at least like to let you know who my staff is on here, if you don't mind, because you'll see their faces, and I think it's kind of good to associate the names with faces. But you probably all know Kim Martone, who's our deputy director. The staff is waving. And Kelly Cinco, who's our director of healthcare innovation, who you may know from her old days, but we stole her.
Nice to see everyone.
Sumit Sajnani, who's and it's important that you all know his face, because he is our new Health Information Technology Officer. So he is basically in charge of making sure the HIE is running right. And he also has charge over things like the all-payer claims database, things like that. Christine Nguyen Matos is here. She is our fiscal administrative supervisor. I hope I got the title right. And I see Gianna Chaparro's here too, who works with Christine. So we had a big contingent here to support the work, but also I think important that you get to see all the great staff we have, even though they're not all here, but a significant cohort is.
Sounds great. So do we have any other questions? And we did not identify who's in the waiting room, but it's not someone with you, Vicki, is it?
I don't think so. I don't recognize that number. Could it be Judy? Is Judy here?
They've disappeared. So.
Okay. I don't know if Judy's here, but I don't see her. But.
Okay, well, otherwise then, thank you very much for your time.
Well, okay, great. Well, it's nice seeing all of you. And as you know, you can always reach me anytime you have questions, always available after hours, before hours, during hours. So thank you so much and good luck.
Thanks.
Take care, everybody.
Thank you.
You all set, Madam Chair?
Madam Administrator, is Have we completed our mission?
You have completed your mission, ma'am.
Thank you very much, subcommittee members. We'll see each other again. And have a great afternoon. And thank you, Sue.